Dr. Swenson. Dr. Swenson, welcome back.
Thank you.
It's great to be talking today already. And almost every day, it seems, that we have something to say to each other. And you're a recent arrivee at Turner Medical Arts. Yes. And we're absolutely thrilled to have you involved with us, and it's a step up.
Very happy to be there. It's awesome. It's a great collaboration opportunity in terms of the overlap with respect to the offering I have, as well as having the network and people for the things that I don't do. Yeah. So it's nice to have that whole practice, so to speak, in one office.
You saved me a whole lot of work, basically, by doing this, because peptides are so common, or the subject is very common now, and platelet-rich plasma and exosomes and stem cells and so on. And it's a jumble of words that we like to be able to seem somewhat intelligent about. And so when I say you save me a lot of work, I wanted to do this. I wanted this to be part of the practice. And Karen felt very strongly about that as well. But it was a whole lot easier to find you and you come and work for us than me learn it all. So now I can just chat to you and ask you questions anytime I don't know anything.
Fire away, absolutely, yeah. I've steered away from PRP in place of exosomes as an example of that list, because the let's call it the concentration. So when you do PRP, for example, the idea, of course, is to spin down the platelets and get the maximum growth factors and stimulants, everything else, et cetera, versus exosomes offer the exact same benefit with a lot less work for the patient and downtime, everything else, and a lot less variability, right? When you get into PRP, for instance, it's, okay, so to say nothing of the age of your, let's be generalized, growth factors, and again, grossly generalized, but if I harvest your growth factors, PRP, spin them down, et cetera, one, I've got to do actually quite a bit of work in terms of getting enough to actually be meaningful. Somewhere between, depending on who you ask, 6 to 8 tubes of blood. That seems not a lot at first, but it's quite a bit.
Yeah, I think it is.
And that blood product is as old as you are versus an exosome, which has the same factors that comes from a newborn. And just to be clear, this is not coming from a newborn as in we've harvested an embryo, God forbid. This comes from umbilical cord, blood, placenta, and other derivatives, which is to say, would you rather get growth factors from a umbilical cord, a brand new baby, so to speak, and the donated products that have never been exposed to background radiation, never been through TSA screening, never been exposed to smoking, alcohol, marijuana, any number of things that the normal person comes into contact with? Or do you want 50, 60, 70, 80-year-old PRP that you get from yourself? Right. That feels like a no-brainer to me.
Doesn't seem like a fair contest.
Right. So that's essentially counter-argument, saying nothing again of the fact that many people don't want to go through the process of, let's call it distilling enough PRP to reach an effective dose. And you can perhaps appreciate that the older you are as you go through a PRP process, I will say in theory, because the evidence is not strong around this, but in theory, the more you need, right? You can easily visualize that if you're 70, you need more PRP than if you're 30. Yeah. Fine. But in either case, you need much more than if you're literally 0. So exosomes from umbilical cord-derived products seem, again, relatively a no-brainer, especially since cost is about net.
Yeah.
Anyway.
And as a provider utilizing this, it's much, much easier also. It's there, you put it in a syringe, and you put it where you want it to be.
It's easier. I would argue it's safer. There's counter-arguments. That's fair. I would argue it's safer in so much as we're not going through procedure. I'm not exposing you to X, Y, and Z. I'm simply injecting. Now, of course, anytime you receive any kind of blood product-derived transfusion or injection, there's always the risks of blood-borne illnesses, etc. We are very diligent, and the partner, again, you're welcome to look them up. If you're the audience here, Regenerative Research Group, RRG, is the one that I turn to the most. They quarantine everything for 14 days. They are FDA registered and cleared. They pre-screen all donors, etc. That is, in the world of how safe you can be, they're about as safe as you can be.
Yeah.
Without exposing you, without subjecting you to a procedure itself. You come in, I inject you, and that's the end of the day.
And they have guidelines that they follow
Yes.
in terms of, or restrictions actually, as to who they're going to use as a source.
Extraordinarily strict restrictions,
Yeah.
which I think this kind of bleeds in very naturally to the considerations around U.S. versus ex-U.S. or non-U.S. based sources of stem
Absolutely.
cells. Origin, and I won't quote the whole owner's manual for the sake of simplicity, but in short, their donors are, at least at this point, actually all pre-COVID, because I still have a 2-year plus supply of pre-COVID stem cells. No vaccinations, never smoked, never drank anything else. And again, happy to share all of the details. So this is a Utah-based company. And as a result of being Utah-based, they have a large Mormon population that is married and has children at a young age. I will not pretend that there is data suggesting that young children versus old children guarantee better efficacy. That would be a lie. But nonetheless, their average parental age, they cap it at 18 to 26 years of old.
Wow.
Which means, again, young, healthy, otherwise unexposed individuals in terms of, again, to the natural stressors of life, in addition to the limitations that their religion imposes. I say that in a non-judgmental way, as simply as it pertains to to the health of the stem cells. So a fantastic product. In contrast to, so you go overseas and, I go overseas and I can get these expanded stem cells line. And I'm like, expanded stem cell line means that they've reproduced the stem cell over and over and over again, which is exactly the opposite of what you're paying for with respect to sourcing young, healthy, umbilical cord-derived stem cells that have not replicated. Every replication exposes you to more radiation, more background stressors, more damage, more everything else in the world, and there's no way around that, to be sure. So inevitably, why would you pay more money for older cells? And that's before we get into the whole conversation you were there yesterday, of course, in terms of the viability of the cells themselves. Because cell count is nothing. I can fill your tires till they're 300 PSI, but that doesn't help you at all if it blows a tire out, so to speak. You still want the high end. Yeah,
what I was fascinated by also was harvesting this. Just the fact that they only get them at cesarean section.
Yes.
And
I'm actually going to flip that to you, because I think it's probably useful for people listening as far as why is that important versus natural birth? Because, of course, naturally you'd think, natural healthy birth must be better than a C-section, but that's...
Yeah, okay, there are a few very basic things, as one of them is called sterility. A cesarean section is not a sterile procedure because it's breaking in through a contaminated area, either vaginally or through transabdominally, but it's as clean as you can get.
Got it.
As opposed to a passage through the birth canal.
Got it.
And any woman that's been in labor or had a vaginal delivery knows that there is a lot of effort and side effects of vaginal delivery.
Sure.
And so you can't be sure that this product is absolutely sterile coming out of there, but it's as good as you can get.
Yep.
Makes it, and it's also organized, because a lot of those would be scheduled C-sections. They would, because those patients that are going to be used for this purpose, a part of this process, will be having planned this for a while.
Yep.
Because they've got to do all the testing and so on beforehand to make sure that they fit the criteria. So it's planned, it's arranged, and it's perfect. And then it goes straight from there into beginning to be put into a workable situation, to a product that can be used right away without freezing at that point.
Yes.
And I think they've been brilliant in
launching the chain of custody and everything else in terms of they're in the operating room for this. And so I think it's worth double clicking on for a moment. So yes, it is as sterile as you can get, so to speak. I think it's perfectly sterile. But for the sake of not confusing the issue, I think it's worth touching on the fact that even if you did an adipose-derived stem cell, the procedural aspect is, unless I'm mistaken, please correct me, effectively identical sterile
Yes.
field, sterile surgical field,
Right,
etc.
right.
Once you cut in.
Yes.
So this is as, in both cases, it is as clean as you can get because nothing is perfect. I think it's worth calling out because it's not like you're sacrificing some degree of sterility by going with a placental and umbilical cord derived stem cell versus an adipose derived stem cell, which is a whole other conversation in terms of downtime and everything else.
And quality of stem cells,
Correct.
too.
Yep. Yeah. No, so again, a Regenerative Research Group, like I said, is the name there. You're welcome to look them up, read into them, etc. Nothing to hide, so to speak, in terms of that. They are an FDA-registered cord bank. I'm happy to answer questions if anybody out there want to talk about it further in terms of options and benefits, this versus that. I think one of the things that people probably don't, I should rephrase me, one of the areas people probably question is, what are the differences between different kinds of stem cells? And in short, in the US, you can get what's called mesenchymal stem cells, which in English means stem cells that have already differentiated a little bit. So stem cells start off in an embryo being able to do anything they want. They can become an eyeball, they can become a kidney, they can become your brain cells, etc. As they get older, they differentiate, and as every step they go through maturity, they can become less things. They've already decided, I can only become brain tissue. I can only become whatever tissue. The ones that we get from umbilical cord bloods are called, again, mesenchymal stem cells. And I'm not going to go too far down the rabbit hole. At least evidence-wise, they can, quote unquote, only become bone, cartilage, musculoskeletal, and tendon. And the US has said, okay, it's okay to use those stem cells, totally legally across all 50 states, to regenerate exactly those organs. So injuries with respect to tendon injury, musculoskeletal injury, etc. Younger stem cells, and we're gonna park ethics for a moment because that is a very complicated conversation. I'm not gonna bother getting into it. Theoretically, overseas, you can get true embryonic stem cells. We all know what that means. There's two caveats here. One, there's no FDA overseas. As the crass saying goes, good luck and God bless. I don't know what you're getting. There's no way to guarantee it. Second is there's something of an ironic effect here, which is if you do receive embryonic stem cells, when they are so young, again, I love the children mentality in terms of if you think about stem cells, when they are so young, they're babies, they don't know what to do. Of course not, right? A child does not know what to do in a given situation. When you put those stem cells into your body, they don't know when to stop growing. They have a high tumorigenic potential. That is just what it sounds like. They can become tumors. Right. If you're even receiving stem cells, if you're even receiving human stem cells, if you're receiving live stem cells, those were frozen. How long ago? Who knows? If you're receiving stem cells that weren't, as I say, expanded, what if they took, again, for the sake of simplicity, they took 100 embryonic stem cells and made them into 100,000. The number of divisions that requires means you have cells that are very old in relative terms. You can't track any of that.
Right.
Again, good luck. I don't know what you're getting. No one else does either. You're counting on good faith, essentially. I have a lot number for every stem cell and exosome I get. I know where it came from. I can trace it back to the donor. I can trace it back to how long it was quarantined for. Everything else is registered with FDA. They have to acknowledge, if God forbid there's a problem, they've got to call me and say, look, this is what happened. Yeah. And while problems are rare, at least I know.
Is that a thing? Are people going overseas to get exosomes?
Very much, because I'm going to somewhat arbitrarily call it 10 years ago or so. Don't quote me on that number. Until then, give or take, stem cells were completely illegal in the United States. And a number of, let's call it clinics, built their reputation on offering stem cells overseas. I'm not going to judge anything that was done there. I wasn't part of this practice. Maybe they were fantastic. I have no idea. But they run off the credibility that, oh, the US didn't offer stem cells. And unfortunately for most consumers, there is still the mentality that stem cells are completely illegal in the US, and that is not true. They are, in fact, legal in the US. They are not FDA approved. They are very similar to an off-label drug. Hey, there's no promises, we make no guarantees. No different when you're overseas. But you can get them in the US, and they are tracked and recorded and documented and chain of custody and everything else. And you have accountability from both your physician and the cord bank that sourced them. You're not flying in the dark.
Right.
They're not any more expensive. They're in fact cheaper.
And people are using them as an alternative to surgery most of the time, right?
Yes, that is the most common and most well-accepted use case, because based on the, I can get down a quick rabbit hole and I'll sidebar for a moment. Theoretically, umbilical cord blood-derived stem cells still have the potential to go a little backwards and could, in theory, become nerve, kidney, heart, liver, etc. In theory. That requires an injection by IV, which the FDA says not kosher, fine. And even if you did that IV injection, the majority end up sitting in lung tissue. Less than 10% will leave the lungs. And at that point, 13% of the theoretical quote, let's call it 10%, about 13% will leave the lung tissue if you were to do IV. And of those, you are now really in a crapshoot with respect to what percentage have the ability to further revert to some alternative stem cell case. Simplified statement, apologies for the tangent, is in the US, you have access to umbilical cord derived stem cells from live birth human babies with no ethical concerns, I should say, that by and large are a surgical alternative to large tendon and muscle injuries.
And they're not going to go to the lung or the...
They can still translocate there a little bit. That gets into the technique and the competence and strategy of your clinician. There are ways to limit what they call the transmigration. So
yeah, that's what we talked about yesterday, and explain that process.
Yeah, so for the sake of simplification...
Let's just say it's a hip.
Yep. So why would you ask that?
Let's say.
I inject stem cells into you for a hip injury, a shoulder injury, whatever it may be. I inject locally. Those stem cells are primed to go wherever they have signs of inflammation and damage. Most people over 4 years old, literally, are going to have some inflammation or damage, right? You have injuries, you have everything.
Everywhere.
Things hurt, right? Mm-hmm. You've fallen down, you have this, you have whatever. The point being, so once you've injected those stem cells, they will go wherever they need to go. That's good and bad. The good is, of course, you get whole body healing potential. The bad is relative to the trillions and trillions of cells in your body. If I've given you 10 million cells in your shoulder, as a percentage, it's nothing. So as they move throughout your body, you have no real impact. What that subsequently means from a strategy perspective is when giving stem cells, you want to be sure the person is generally not inflamed, and there are a number of ways to go about that, everything from peptides and medications to lifestyle changes, etc., and they're all very personalized, to marrying the stem cell injection with exosome injection. We can go down that rabbit hole in a minute, but in short, it means that we can give particularly agents, that is exosomes, that will trigger the stem cells to be most active in the affected joint or area of injury, minimizing, never eliminating, but minimizing their potential translocation to the body. Simplified version, I give you exosomes and stem cells in one joint. The exosomes say to the stem cells, stay here and fix this shoulder. Don't go over to the kidney. Don't go to the other shoulder. Don't go anywhere else. Stay here. Fix this. And so the strategy behind how we give it and why we give it. And again, this gets into one of the biggest failure points for stem cells is a failure to adjust your lifestyle habits accordingly. And my grossly simplified version is you don't give beer to babies because it's not good for babies. You don't give whiskey alcohol, you don't give cigarettes, marijuana, etc. to your brand new stem cells. You don't skip sleep. You don't do all these things that could exacerbate your inflammation. You would never let your child skip a nap at 1 year old. So too, go to bed, get your sleep, don't drink, don't eat inflammatory foods, get off sugar for a month or so. Let this work because you quite literally just got effectively baby cells. Treat them like that and they will work. Abuse them and they will die.
Now, what could one argue that, oh, maybe if this person went off all the anti-inflammatory things and habits, would there be an improvement on their condition?
Oh, to be sure. Absolutely.
So do you make people go off all that ahead of the injection?
Yes, as much as possible. I should say, yes, I make them do it, and I make them acknowledge that they're not doing it. They may spend a lot of money to get nowhere.
Okay. So it's probably like how many weeks of prep before someone does?
Usually 2 to 3 weeks is sufficient, depending on their current lifestyle. And again, I get athletes who are on top of their game and already doing everything right to the average weekender who just got injured by default playing pickleball or tennis and leads an average American life. No criticism intended. And those are two very different people. One, all right, let's get your HSCRP and CRP levels and go through everything else and see if we can optimize this. And do we need to put you on anything beforehand to minimize your inflammatory protocols? And are you on board with this, et cetera? And the other is clearly already teed up. I think one of the other big failure points for this kind of therapy is the misconception that, sorry, I'm gonna give it from an example. If you came in to me, I don't do surgery, but if you came in and you needed a shoulder surgery for a tendon tear, you'd understand that I cut into your shoulder, stitch up your tendon, and I'm going to tell you as a surgeon, you have your downtime. Your tendon's not healed yet. You have this big scar on your shoulder, etc. Oh, okay, that makes sense. I'm going to listen to my surgeon. I can't play baseball for a month. I can't whatever for the next 3 months. You come to see me and you get a stem cell injection. I had a needle in your arm for about 10 minutes. You have no injury. You can drive home the same day. There was no anesthesia or anything else. And there's a misconception that, oh, this is a minor procedure, therefore I'm good to rock and roll. But it's not true. The cells take a long time to work. They need to grow. They need to settle in, so to speak. They need time to differentiate, to become the mature version of themselves. And that can take easily 8 to 12 weeks, if not more, depending on, again, your other inflammatory considerations, et cetera. So these are the areas that people fail. They fail in the lifestyle sense. I continue this average American high sugar, drinking, alcoholic, drinking, smoking, poor sleep lifestyle. Or it didn't feel like it hurt, so I can probably go running the next day after my hip injection. And you can't. You drive that level of inflammation and the cells die off. So this is the massive failure point, and this is why I'm so deliberate when doing this. Do you really understand what you're getting into? And for athletes, it's really infuriating. You got injected in your shoulder and you feel great. I'm like, I can use the other arm. I can extra. And you can't. Nope, you're done. You are sitting still all summer long, and people are not exactly happy about this.
No, I imagine.
What about going off a little tangentially?
Please, sorry.
If there is an acute injury,
yes,
and you have the possibility of treating a patient there and then, is that the best time?
No.
Good to know.
Typically, you'll wait, depending on the level of injury and the person's lifestyle factors, anywhere from 2 to 4 weeks. The literature is, we'll say, fairly consistent. That is the ideal window. Let's call it 3 weeks for simplicity. And the reason being, you're trying to strike this perfect balance of not too much inflammation and irritation to kill off your newly injected stem cells, but enough inflammation and irritation that they localize to the area of injury. So there's a bit of I won't say fine balance, because that suggests the science is perfect. It is not. But there's a bit of a balancing point. And okay, we don't want you that day to get it. And there are ways to reduce inflammation aggressively.
But you could start them on peptides.
Correct. You got it. Yep.
And do you do peptides?
You were listening yesterday.
And then you do peptides. I know it probably seemed like I wasn't, right?
I didn't say that.
No one can
Or
see
you
me.
already knew this. That's
No,
the
so you
know
start
evil,
them
I
on
don't know.
peptides, but also are they doing peptides after the injection too?
They can, yes.
Okay.
It can drive further angiogenesis, so new
Okay.
blood vessels, etc. So, in fact, everything you're doing around this, depending on your willingness, is meant to both minimize the inflammatory background noise and maximize success of the stem cells. And that can include, again, based on your current lifestyle habits, injuries, and even need for recovery. So these are not real stats because we don't have data to support real stats. These are anecdotal. That means we get these data from people who self-report, et cetera. So take that with an appropriate grain of salt.
But what are your patients' stats?
That's what I was going to say, right? Which is, so as an industry average, give or take, you'll hear about 70% of people need just one injection. Massive caveat around that. So don't quote me on this too hard if you're seeing me as a patient, right? About 70% of people need one injection to get to where they want to be from a recovery perspective, assuming lifestyle considerations are in place. That doesn't mean the other 30% fail. The question is, how good do you want to get afterwards? This is very similar to the surgical question. When you do surgery, how much surgery do you do for recovery? So these numbers are not
It's okay.
truly verifiable. We don't have good raw data. This is all biased data. But anyway, let's call it 30% of people say either it didn't work at all, I'm done, or it worked pretty good, but I want to get back to 100%, not 90%. So they want another round of injections.
And how long do they wait?
I usually will not consider another round to at least 8 weeks, typically 12 weeks, to really see how we're doing, what the recovery is, et cetera, and make sure we optimize from that accordingly. Because again, this becomes very personalized. It's not just how much did you get for stem cells. It's also what's your physical therapy and recovery plan. Do you have a good PT to walk you through a good rehab consideration on repeating imaging and how often? All this comes into play.
Yeah.
Are you a pro athlete or are you a weekend warrior? Those are very different statements.
It's the same with surgery. To
Exactly.
You, same things you
and the
would
failure
do,
rate and
so-
everything else, they're very, at least from the, again, acknowledging FDA considerations, what we can and can't say, you're approaching very comparable failure rates, surgery versus stem cells. The self-serving plug would be, I can re-inject stem cells much easier than put you back on the knife.
Yeah.
Yeah. I think people injure themselves so much of the time by doing the wrong exercise. They're stuck in a pattern that is actually hurting them. And I see it with a couple people I know really well that have problems where I'm like, yeah, but you are continuing to do these things that are creating these little tears and problems in the area, but you're stuck in that pattern of fitness, thinking that old pattern is what you're supposed to be doing to be fit.
Yes.
But so I could see how, whether they're having surgery or the exosome treatment, that they'd have to really look at that and get in a different pattern, or else they're just going to create the same problem again.
Yep. No different surgery, 100%.
And I think people are really stubborn in that way. That's a hard thing to change with someone.
Me too, but yes.
I really think that's a hard thing to change. Even for myself, it's me saying all that and I'm aware of all that. It would be a hard thing for me to change.
It is. Everybody who's active wants to stay active, and downtime is just
especially
brutal.
people that do yoga. People that do yoga are really stuck in that. Right?
Yoga, I see it with golfers, cyclists, and
Golfers
skiers.
cyclists.
These are three people who do not want downtime, like at all. They're like, oh no, I can power through this. I do not want to miss my season at all. They don't know.
Oh yeah, golfers.
Oh God, no.
Yeah.
I guess pickleball's on the rise in that space.
Oh, pickleball, all the pickleball injuries
Yeah.
in Santa Barbara.
Yeah. Now, all the pickleballers listening, please come on in. You will make me very well
You
pleased.
need to start. You need to start playing pickleball.
I don't play pickleball. I don't want stem cells. I'll take my injuries from mountain biking instead.
No, but you need to go meet all the pickleballers. Anyway, I got a good person to introduce you to. Actually,
I'm on board.
I have to introduce you to Robin. Yeah, she is the pickleball person.
Don't know. Still new to town.
Yeah, close friend. Good. Do you have anything else?
I rambled a lot. I'm sorry.
I really like how this got very specified into the stem cells. Because there's a lot we can talk about here.
Oh, there's a lot to stem cells, to say the least. Yeah.
But
one of the things I was fascinated by yesterday, talking to the people that are in the factory, was
the blender factory.
The blender factory is getting the stem cells and or exosomes, or perhaps the other way around, to what they've got to do. There were 5 categories of treatment that were discussed, and number 1 was orthopedic,
obviously.
But down there, number 4 or 5 was.
I think it was number 5.
Sexual medicine.
We all noticed.
and that in my field is crucial because. One of the really great things that I've experienced is this change in gynecology, that now we're actually talking about life, and we're talking about sex and satisfaction and things working well when you don't expect them to, or people be aging and they're starting to get any of those symptoms of diminished sexual satisfaction from 30 on. And just that's why they were a little vague yesterday when I said, what do you mean? Which procedures are you talking about? But there are pelvic floor issues, and there are circulation issues, and there are hormonal issues to all of this that all could use a leg up. So how do you, let's say, just tame your dragon or tame your stem cell to do the right thing, to go in the right place?
Absolutely,
How does that happen?
So essentially the underlying question is, how do exosomes play a role in what is, of course, an exosome with respect to making sure the stem cells do the job that we've just deployed them to do, so to speak?
Right.
For a little background for the audience here, exosomes are very often quite poorly defined with respect to what they do and what they are. The way I'll hopefully explain it in a way that makes sense is cells communicate in a number of ways, including direct electron communication, so they pass sodium, calcium, potassium between each other, etc., in a number of the ways. And I'm going to grossly oversimplify this, but let's say that they can communicate through electrical signals in like a postcard. They send a single message. Another way they communicate, and the one that's relevant here, is through what they call exosomes. And so the cell membrane, what makes up the cell itself, can...
Here, I'm going to fix your mic.
Okay, I'm going to pause for a second.
Just stay on can.
Okay.
Yeah, the other way. Yeah, that's right.
I'm sorry.
Okay.
And now put all of your weight behind it.
There is no weight.
One thing I want to ask, if people are on GLP, is that going to help you?
Hard to know. We don't know. We don't.
I think that's going to be okay now. Oh,
Damn.
put that extra bit.
This one used to never move.
Thank you. No, it's fine. It's just...
Duncan, you're fine.
You get no attention.
You're fine. Works for me.
Okay, can. Who's on the can?
Yep.
Exosomes can.
One of the other ways that cells can communicate... Oh, I'm waiting. Hold on.
We went from can.
We'll start it again.
Okay, go ahead.
So there's a few ways cells can communicate. One of the simplest ones is chemical communication. So they send, whether it's sodium, potassium, calcium, etc. And you can think of it like a postcard or a letter. They send a specific set of instructions saying, do this or that. Easy enough. Cells are not rigid structures. So pieces of the cell membrane can quite literally pop off. For the sake of an analogy, it's if you could pull hair out, quite literally. And in that hair is a whole bunch of information. So you can think of an exosome for a moment as comes off of the cell with a bunch of information, okay, like a FedEx package. It comes off the cell membrane. You can think of a little balloon that pops off of a bigger balloon. And inside of that is a bunch of instructions. Now, those instructions can be, well, very wide-ranging. I'm not going to get into all the details around what an exosome may or may not carry. As it pertains to this particular use case, the exosome can give instructions that say, all right, you, Mr. Stem Cell, are going to become nerve or kidney or bone or muscle, etc. Stem cells inevitably, release this in some level or are accompanied by this. The more mature a stem cell becomes, the farther along it gets, so to speak, in terms of, hey, what am I going to be when I grow up, the more narrow the type of exosome it releases. When it's a brand new stem cell, as an embryo, the exosomes say, become anything you want. When, you're, again, these are very arbitrary statements. When you're 16 weeks along, some stem cells say, I'm going to become an eyeball. Some say, I'm going to become a kidney. They're releasing exosomes to reinforce that. In the lab, there are a few companies, RRG is one of them, that have been able to say, okay, we're going to take this stem cell from the umbilical cord. We're going to prompt it to release exosomes that signal become a hair cell, become blood vessels, become cartilage, become muscle. You can see where I'm going with this, right? Mm-hmm. So they prompt that. The way these things interplay is that they create a basket of exosomes saying, all right, all these exosomes signal become muscle. I inject those exosomes first. First being relative, that this is done hand in hand. This is a procedure that lasts just a matter of minutes. I inject them first, and these are all a bunch of stem cells saying, I am going to tell, a bunch of exosomes saying, I'm going to tell local stem cells to become muscle. I inject the stem cells right after that. Now the stem cells are flooded with information saying, oh, we're going to become muscle tissue. Okay, great. This is our job. They are less likely to leave the area. They are less likely to become something else. Now they're localized. They've got all the right signals to grow up into muscle. So too, as it pertains to sexual health, much of this is redundant with becoming appropriate blood vasculature, unsurprisingly, as well as some degree of neurogenesis, so nerve cell differentiation. Anyone can appreciate, of course, that sexual organs are, of course, stimulated by the appropriate nerve endings. So to that end, the exosomes in that area say, all right, if we inject stem cells right after the exosomes are given here, they're going to become brand new blood vessels. They're going to become brand new nerve endings. And that's the idea behind using exosomes and stem cells simultaneously to to override any signals that would pull the stem cells, one, out of the area that you injected, and two, to become something other than what you're targeting. So that's how those things go hand in hand. Hopefully that made sense.
Yeah. So for sexual health, it's creating, let's say if it's for a man and they're doing the equivalent of what is called a P shot, but it's whatever, that's just a name. Putting it in the penis to create more blood flow.
Yep. So they can work independently, the exosomes that is, because inevitably by themselves, they're still creating signals. So let me back up 1 second, because I think this is why would you get exosomes alone and not stem cells simultaneously? Whether it's in the penis or in the vagina or clitoris, etc., or any number of other areas, you never lose stem cells. You have stem cells right now in your eye, in your hair, in your penis, in your anything else that are growing, right? Your heart didn't die. It's still, the cells die every minute. There's new ones every minute, and those are coming from stem cells. They're getting older with you, but they are there. The exosomes can drive them to say, oh, okay, I'm getting extra signals to differentiate, to grow even more than I usually would. This is the exact same mechanism behind why both PRP and exosomes can drive hair growth. Your hair doesn't stop growing. It doesn't grow as well as it used to, but it keeps growing. Then you inundate it with a whole bunch of messengers, exosomes, PRP, similar idea, saying, you need to grow more. You can think of it like Scott's fertilizer for the field. You can spray all of it you want to. It will trigger the field to grow more. You add stem cells, you can grow better grass. But even if you don't have the stem cells, you will still grow more grass just by spraying your fertilizer, so to speak. This is the idea behind exosomes.
Very exciting.
Yeah, it's good stuff.
It really is. There's way more to talk about. And
a lot.
Come back again next week.
I would like to.
Yeah, this is your second time on the podcast. We didn't get into the emergency medicine concierge style that you're doing. You want to talk a little bit about that?
Yeah, sure. I'll keep it fairly succinct. I'm sure everybody listening by now is probably tired of my voice. I'm sorry. All the same, one of the impetuses, the major impetus behind what I'm doing here in Santa Barbara, Montecito, is emergency medicine combined with regenerative therapies. And to put that quite simply is there are a number of regenerative protocols, whether it's peptides, stem cells, exosomes, IV therapies like high-dose vitamin C and zinc, etc., that we know work, right? You go to a regular emergency department, and I'm not criticizing them. I was a regular ER doctor for many years, and they follow standard protocols. Okay, so you're sick and this and that. We're going to put you on your Tylenol, or we're going to tell you to take some this or that for your sprained wrist or for your injury. They're not going to hit you with ozone therapy for your flu. They're not going to hit you with peptides for your sprained wrist. They're not going to schedule a consult for your torn tendon and stem cell considerations. They're not going to, talk to you about a number of high-dose vitamin C because you got COVID, et cetera. And that's not a criticism. That's simply just not the way a hospital system works. And it occurred to me, I had some random light bulb moment for a story from another time, which was I was seeing a lot of my clients in the regenerative space, a few days, a few weeks, and a few months after they'd been in the ER for their recent injury or illness. I'm like, wait a minute, why don't we just bring all the regenerative therapies to the forefront and, give you all the best tools at the moment of injury or illness? Why wait? Why tell you to go follow up with your primary care regenerative doctor 3-4 days after a COVID test? Why not get it today? Why not start ozone therapy right now? Why not put you on peptides and BPC the moment you sprain your wrist? It's became so unbelievably obvious to bring all these cutting edge therapies to the forefront. Of course, that's to say nothing of avoiding the emergency medicine department in general, which is, as anybody who's been through it, whether on the provider or patient side, and I've been both, is a tough place to be at 2:00 in the morning.
Yeah.
There are better options. So even if you don't need any regenerative therapy, it's just simply a cut on your hand that needs some stitches, fine, we can do that. But that was the impetus and simply the birth of Cavalry Health, is bring all of the cutting edge tools to the forefront. So maximize healing and recovery rather than waiting. My last guy, we talked about this for a moment as far as ideal window for stem cells. Yes, there is an ideal window. It's not the day you get hurt. But he saw me 3 months afterwards. He lost his whole summer. Wife is frustrated, understandably, that he can't do anything with the kids and he can't lift and he can't move his arm. We could have done this day zero. Started him on peptides day zero, got him on the stem cells within 3 weeks. He'd be up and running right now. Yeah. But no one talks about these things because it's not part of the standard protocol.
So how are you going about changing the field?
I wouldn't say I'm changing the field, because changing the field implies that I can change the current structure, such as the hospital systems, insurance, etc. That's not going to happen.
So what do you think is a better way to do this?
Having someone like Orel on speed dial.
I'd like to think that I'm a better way to do this. Exactly right.
That's exactly what I'm asking.
Yeah, that's what I mean. What it comes down to is, of course, there's nothing wrong with the traditional approach. I did it myself for many years as a physician, obviously. But there are handicaps around that approach, because what does insurance reimburse? What do pharmaceutical companies get paid for, et cetera? Stem cells and exosomes aren't covered. Peptides are not reimbursable or patentable, et cetera. High-dose vitamin C, despite excellent data around it, there's no money to be made, so no one offers that. So we don't talk about it. These are things that are and should be available, but I'm not going to fix the system. This is why I've chosen to work outside of it.
Like many have in our area. So.
Oh, good.
I'm excited. Okay, great. you.